Head, Division of Child Psychiatry, Jewish General Hospital, and also a psychoanalyst. Dr. Guzder has been the Director of Childhood Disorders Day Hospital at the Jewish General Hospital, Senior Consultant and Co-Director of Jewish General Hospital Cultural Consultation Service, and Associate to McGill Faculty of Social Work. She was the founding Clinical Director of Cultural Consultation Service in Montreal until 2019, focused on mental health work with the refugee and immigrant population. She has continued to work on global health projects in Jamaica, Ethiopia, Brazil, Sri Lanka, Nepal, and India. She is a third-generation South Asian settler in Canada and a visual artist. You can, of course, see some of her artwork on the slides itself, which will be visible after some point of time. Her current clinical appointments include consultant psychiatrist for Vancouver Island Counseling Center for Immigrant and Refugee Population, or WICIR, and ICYMH, Indigenous Child and Youth Mental Health. Professor Guzder has co-edited the book Cultural Consultation, Encountering the Other in Mental Health Care, published by Springer in 2013, which will be available in IIT Pala library very soon. With this, I would like to welcome Professor Guzder once again. IIT Pala.
Thank you. Shall I begin, Dr. Kotai?
Sure, you can begin.
Thank you. Thank you very much for your welcome, and thank you for inviting me. Just to say that Dr. Kotai was invited me to speak to his concern about the rising vulnerability of suicide in young people in IIT and other faculties and so on. And I am not an expert on India, so I'm going to talk about my experiences, and I hope it can be of use to you in considering this issue. I'm beginning with a land acknowledgement. In Canada, we are settlers here. I have come since my grandfather's generation, and we have taken the land of the Indigenous people. So this is my acknowledgement. Normally, I live on the West Coast. I happen to be at the moment on Mohawk territory in Montreal. I thought I would start by acknowledging my many friends in India and on the subcontinent who have helped me to understand. I have lived in Mumbai for 5 years at one point in my life, but these are the people that I work with in my profession over the years who are doing some very impressive work on the subcontinent on the issue of resilience and youth mental health. So if you are aware of these remarkable projects, the Bapu Trust in Pune, Dr. Davar, the wonderful work of TIS, the oldest social work institution in the country, SCARF, which has been a remarkable center for first episode psychosis treatment, the Sangha teams in Goa under Dr. Patel and Dr. Devan and a huge team, NIMH, Dr. Shashadri and Sheila Ramaswamy have been doing wonderful work developing daycare intervention, working with judges, looking at child abuse in India. Dr. Kanwar, who's the first child psychiatrist in Nepal and started all the services there. Dr. Krishna Murthy, who has been a very big leader in disability for children and started the Umeed Foundation. Dr. Murthy, who has done extremely extensive work on disability. Dr. Somasundaram, who has worked on the refugee issues of Sri Lanka after the war and during the war. Dr. Skandar and Dr. Atif, who have looked at postpartum depression and its impact on infants and how to reverse that. Dr. Kakar in the Tara Trust, who's working with children and other projects in Goa with art and other issues. And Dr. Kotai, thank you very much for your contributions to my learning, because global health is a reciprocal process. Well, the first thing I would like to say about youth resilience is it's a very complex process. And it involves the individual, it involves the systems in which we live, including our families, and it involves the collective gestalt around us. So if we want to change youth-oriented policies in a university or anywhere, we have to attune ourselves to many different levels. Schools are very important and foundational as an environment for youth development. And our attention to childhood adversity and the fact that childhood adversity is something that follows us through our life cycle and that we need to work with, all of us, if this is a part of the experience of our youth and our childhood. And we understand youth as being from age 10 to 24 now. We no longer talk about adolescence as ending at 18, because these are the years in which identity and formation are important. So the ideas of equity, diversity, and inclusion are extremely important at this time in our societies. And the building blocks of resilience are our connection to safe and enduring relationships with emotional safety, shared values, and trust. These are the things which we are really emphasizing, and we have to understand that many, many people in our societies are invisible and they are not heard. And this is the relationship that Mahatma Gandhi spoke about our responsibilities to the most vulnerable members of our society. Well, Dr. Kotai mentioned to me that the youth suicide rate is very important, and the national statistics emphasize that they're underreported in India. There is tremendous stigma about reporting or coming for health care in youth and families. So we have to understand, since COVID, there is some worries about youth and children, and also about distress that is not addressed. The highest risk groups are those who come from minorities, those who have disabilities, and therefore we have to think about in what way our institutions are showing empathy for those groups. In fact, higher education is extremely competitive to enter. IIT is very famous across the world. My son was very impressed to know that I was speaking with you, because you have a tremendously good reputation. But the fear of failure and the shame and guilt that go on within each student, sometimes if there are difficulties, the parental expectation, the collective expectation, the worries about economics, do make failure anxiety extremely important. So things like being able to have an optional supplemental exam and so on, these are very important institutional responses to those kind of realities. We need confidential, accessible support. And now, because of virtual lines of communication, there are many interesting innovations. But we must think about our collective efforts. If we're thinking about cultural safety and emotional safety, we have to accept that there are incredibly heterogeneous cultural groups in India. Language skills and language diversity and ethnic skills are very important. So attentive learning and dignity and taking time are very, very fundamental to our work as therapists. And cultural humility is very, very crucial. That is to take the position of not knowing and not assuming and not judging, and being comfortable as therapists with not knowing. We are really striving for listening. If you study to be a therapist, the DSM is not used as widely as the ICD in Asia. However, this is the formulation that is now being used and taught on cultural formulation. And you'll see that elements in the clinician-patient relationship are on this list because our therapist's identity and understanding may help us or inhibit us or be another impediment. So we have to think about how distress is communicated across groups and the variations of how people explain to themselves.
Sorry to interrupt, Professor Guzder.
Yes.
This meeting may end in maybe in 2-3 minutes, so you may please re-log in. It will restart. Thank you.
I'm sorry.
You can continue. You can continue. It may stop in maybe 2-3 minutes. So few minutes are left. So you can continue.
Okay.
Yeah, sure.
Okay, so I'm just giving you this outline. I'm not going to dwell on it because you're not therapists, but that it's very important for us to understand that social scientists and anthropologists and psychiatrists and psychologists and all the people in mental health need to think about the complexity of culture. When I have been working in Canada and other places on refugee and war survival and immigration issues, all of those issues come to us in high-income countries like Canada. And the Cultural Consultation Service was very specifically to help therapists and institutions to think about the barriers and the facilitators of treatment for people who are others. So these are the unmet needs of undocumented refugees, traumatized individuals, or immigrant individuals. And it has a human rights orientation in its practice, but it's also really across all spectrums of psychiatric assessment. And we worked with religious groups, community resources, and we were mediators and really working with families to promote settlement. And such projects as Maison Bleue in Montreal, which was really specifically for immigrant mothers and families, helping when they had high-risk pregnancies and high-risk trauma histories, was an example of the kind of resources that were developed in the community with our support. So psychotherapy is not one size fits all. It is unique and it is between the therapist and each patient. Resilience research is something that is embedded in principles, and there's a great deal of research on it. I'm referring to one particular set of researches, which is the research of Michael Unger across many, many countries. And these are the principles of that research. These are the building blocks that apply to all youth, but are modified by where they are. So their local adherence, their internal adherence. I'm not sure what I'm supposed to do.
Very co-host time.
So, Professor Guzder, you can, it's visible now. Your PPT slide is visible. You can go ahead. You can continue the presentation.
Okay, that was a
Sorry
bit
for the
disorienting.
disturbance.
That's all right. Okay, I was trying to just share with you the 7 principles from Unger's international research on youth about the foundations of resilience from his point of view internationally from their research. That all children and youth are embedded in some kind of values or beliefs. This is part of health. The second is they all have experiences of social justice that they experience through watching their parents and individuals in their community, and they have their own experiences of what social equality and meaningful roles in community mean to them. All youth and children need a sense of cohesion between their personal responsibilities and their responsibilities to themselves to develop socially and spiritually. They need access to material resources, so poverty, nutrition, medical care, housing, and education are fundamental to their health. Fifthly, the relationship of connection between family, peers, and community are fundamental to health. And building these, the last is the building of ingredients of identity, which are personal or collective or about strengths and weaknesses, are extremely important as identity develops. And in youth, all of these things are being rearranged. When we started working in global health on the issues of resilience, we had very little money, especially in Jamaica, in our Jamaica project. And recently I saw this in the paper. This was a week ago. A woman who had a great deal of money to give away gave her money to the medical college to eliminate tuition fees for students. Because she said without eliminating tuition fees, all the graduates, many of the graduates, not all, but many of the graduates, especially of diverse and oppressed groups, were leaving with debts of $200,000. And she said, this is wrong, and how can we support you? And she gave a huge amount of money to subsidize this. But we have to ask ourselves, not all of us have millions of dollars to give. What would we give, and what are the things that we can do, even with small amounts of investment? We have to think about principles of policy and our right to speak out and to advocate. I have been working for the past many years with Indigenous people. Since I came to the West Coast, that is part of my job in southern Vancouver Island. If you are aware, there is a cultural genocide. We have a legacy of having oppressed the Indigenous people. In Canada, we have basically taken a great deal of their land. We took their children away from them. And in fact, South Africa came to Canada when they were formulating apartheid, to look at the policy that we used in Canada to deal with Indigenous people as minorities who had less rights than other people. So we have a legacy that until the Truth and Reconciliation process in Canada was really a hidden and invisible agenda of racism and oppression. And these are things which Canada is now trying to reverse. And so in my work, I see the very long legacy of that hurt. And this has a lot of ambiguous grief and loss and reparation attached to it. It has changes in our politics, in our legal processes. You can download in plain sight from the website of the BC government. It's a report on racism in medical services and so on. And we are really struggling to support the health profession, training people who have Indigenous backgrounds. And there are very few. There are 3 child psychiatrists in the entire country who are Indigenous in their background. And there are very few resources which are run by the Indigenous people themselves. So this is a matter of transition, and also in the integration of Indigenous healing values and their legacy of their own methods of spiritual development are now very, very important for us in our approach to those Indigenous people who are trying to repair and regain their values. So this is going to be a long process. And I thought I would also mention that the person who wrote this report, or headed this group that wrote the report in plain sight, the judge who did it, depicted herself as an Indigenous person, but in fact was not Indigenous. And this was quite a scandal. People who then take on the legacy of being Black or Indigenous in order for themselves at this time to promote themselves. It's a very strange political agenda that's now emerging. My first major global health project was on war surviving populations, and I worked in Nepal and Sri Lanka. But the longest project I worked in was with Fred Hickling in Jamaica. And the reason that I was working in Jamaica for so long and have continued to work there is because many of my children in Montreal in the day hospital were from Caribbean families. The Caribbean families and the Black families, there have been Black families in Canada since the 1600s, so this is not new. But the issue of slavery really goes back for at least 400 years. But the issue that Fred brought was the very detrimental risk to children in the post-slavery generation. They, unlike most nations, do not have high suicide rates for children. They have, however, in youth, they have high homicide rates globally. But they have very high-risk behavior issues with children and adversity, school dropout, and violence, and child abuse. child maltreatment. And again, we had very little money and very little resources. So we thought, where would we put this money to stop or have some impact on this problem? And we decided that the place to start, because parents were not coming with their children anywhere close to mental health, there's too much stigma, that we would start by changing schools, and elementary schools in particular. And that is what we focused on, is getting children into high school in the first place so that they wouldn't drop out, and having a foundation that gave them and equipped them with the skills socially and behaviorally and in their emotional life to handle school. This is one of the historiograms that psychohistoriograms that Fred used to use, and it was about something that we used in group work. He used in group work with adults in the mental institutions. In fact, he was part of decolonizing the mental institution and emptying it in Jamaica. Every colonized country had very large asylums, as you know, including India. And I have visited Kerala's asylums a long, long time ago, in the 70s. And and psychiatry did as much as it could to release people from institutional care and into community care. But genocide issues such as slavery are very deep. And so the agenda is that nobody teaches it in schools, and how do people understand how this has impacted them? So this is something that interested Fred a great deal. And we didn't do this with children, but we took the principles of group work and eliciting their own ideas about their place in society, that as crucial to understanding them. These are children that came from poor homes, and we offered them a treatment. We began with a pilot project, and then we worked with a school to advance literacy and to work with children in groups. And we used art and music as one of the other adjuncts to helping them communicate. And this is and at the beginning we had almost no money, so we were using anything we could get as a musical instrument to begin. And this man was one of our very important musician artists who worked with us. He had Mambala was a wonderful empathic male role model of empathy, who really believed that if we were going to change violence in Jamaica, we had to give children a different experience of themselves. We had to give them a voice. And that was the basis of a continuous question that Fred had, is who wrote our history, who tells our story, who listens to us, how often do we listen and engage with children and families about the transmission of their cultural beliefs and their oral challenge. And it's about oral traditions, not written ones, that were very important in this process. This is the mental hospital. This is the theater that the patients built themselves, and they performed plays which they wrote in circle using a psychohistoriographic approach. The government later tore down this theater, which used to attract a lot of public interest, because they thought it was far too radical to have patients actually performing in public to everybody. So there was a reversal of this movement. This is our children in 2013 in 4 elementary schools performing their own plays that they wrote and put to music and performed for their communities with their parents. At the beginning, only a couple of parents would come. By the end of our project, we had a huge outpouring of children. Okay, I realize that somehow you may not be hearing the children, so I will tell you what this is. This is 100 children on the stage at one time performing a song for their parents and for their communities that they wrote. And it was a spectacular performance in the downtown of Jamaica, the uptown of Jamaica, that the ghetto children in Kingston, Jamaica had never been to. They had never been out of their ghetto. So this was quite an extraordinary event. I'm sorry that the sound is not getting transmitted properly. Okay, so how does these themes that I'm talking about, how does it translate to somebody in university who's at a different maturational stage? And what does social connection and dignity have to do with their wellness? That is, I guess, a complex question. And it depends on lots of relational legacies and lots of fundamentals that give you strength. So there are those people who come from less adversity and those who come from relatively secure settings, who might belong to more dominant power groups or less empowered groups, etc. So we don't have any rules about this. Psychologically, that is not how we understand development. We have to understand it as a unique journey of each student. And each university also is a community that is unique and has its own tensions and influences and realities. And so this is simply to say that the generational foundation and the family foundation continue to be an influence throughout development. Now, I have tried to go through this very quickly because I thought it was very important to have discussion. Joseph Campbell always said to youth, follow your joy. And that is how I'm going to stop this presentation, because I really wanted to give time to the audience. I will stop it here.
Thank you, Professor Guzder, for that interesting talk. So we will take a question from the audience now, if there is any questions. So there are some of the students present here in person, and there are a few who are online. So if you have any questions who are present over here, please do ask. Any questions? So I think there are any questions on the. Okay, so Professor Guzder, I think there are no questions from the audience. We have a thin attendance basically because of the timing. It's 4 o'clock here when most of the students are in the lab classes. That is one of the reasons. So, but I would like to ask you one thing. Now we are also talking about not only cultural competency, but also structural competency. So can you please explain, like, how do we go about it and what is the crucial difference?
Well, there's a very great difference between adversity that we can measure on something like the ACE scale, which is adversities in childhood on trauma, and structural difficulties. Now, on advocacy committees that I sit on for the Canadian Psychiatric Association and the Child and Adolescent Association, and we are looking at structural issues. We're looking at who gets into medical school, how do we support people who have very little, have had a lot of adversity in their development. How does the university promote and help those people? This has particularly been evident since COVID. There are two things in the North American setting that influenced the structural issues. One was COVID, where it was really clear that people have different access to service. And the other was Black Lives Matter. That is, it was it was very evident that Black people and minorities, including Indigenous people, had very different experiences of equity. So those are the kind of issues which are now evident in the university, which were never evident before. Like, who is on our faculty? Who do I go to for medical care? Is there some kind of way that medical care could be more person-centered? Does it make a difference to the outcome of therapy and medical services? So structural issues are considered as important now in changing education as thinking about the individual and supporting the individual's learning, or or looking at their psychological distress. If we think about the suicide rates being increased for youth, we could say that around 25 to 35% might be due to neurodevelopmental, genetic related issues. But the majority of issues that lead to youth suicide are social, they're familial, they're about loss of partners, they're about dislocation and grief. So those are the things that we have to think about. How do we support those invisible problems and those children to feel safe to talk about this and get support?
Thank you so much, Professor, for illuminating on structural competence and cultural competence. And lastly, I would also like to ask about the bullying that happens mostly in classrooms. So we see different forms of bullying. For example, in certain higher education institutions, we find myriad forms. Like, for example, a person who got higher rank, for example, in a competitive exam like IIT JEE, might look down upon a person who has actually got low rank. So it takes various shapes in many schools and colleges and institutions. So how do we actually, as you mentioned earlier about in one of the article that you shared on triadic involvement. So can you elaborate on how bullying can be tackled in the class, even with the support of the students, not necessarily by the involvement of mental health professionals always. So can you please?
So now what you're bringing up is the health of the classroom, and then we have to immediately start thinking about power, because structural issues always go with power issues. Okay, who has a right to talk? Who has the right to confront the bully? Who has a right to change policy? Who is going to protect you if you're bullied and you're from a less powerful group? And how do you teach children if the person at the top doesn't model that for them? So that's why in our project with children in Jamaica, the teachers were an integral part of the change. We started with the teachers. We started by teaching the teachers about neurodevelopment, about resilience, about social skills advancement, about how to deal with bullying. And then those teachers went into their schools working with our project groups, and it was a mutual learning experience. And so teaching about the response to bullying rather than ignoring it or suppressing the information or pretending it didn't happen, that's a problem first of the powerful person. The first person I would ask is, what did the teacher do? Did the student feel that they could go to the teacher for support? Was there an acknowledgement? Was there any role playing so that the children would know what to do if somebody was bullied? And etc. So if we don't start talking about this and sharing information with children, how will they be able to sort that out? It's the same whether you're in university or whether you're in elementary school. It's very important for us to think about what can we give children and youth that equip them to deal with this in the workplace, in the classroom, or in their life.
Thank you so much, and I cannot wait to ask one more question. I've actually having had so many years of experience working with one of the most difficult, one of the youth and children in most difficult circumstances, like the immigrant youth. So, can you share some of the experiences where you have used cultural safety, cultural competence, any of the cases that remains in your mind that can be shared with us. That would be wonderful.
Well, it's fundamental to our work, actually, with both the indigenous people and with the refugees and immigrants, that, by and large, immigrants do very well in Canada, and their mental health distress, it becomes less over time. Okay, so because we are a very well-to-do nation, we do have resources, but there are some subgroups who do really struggle. One of them is the indigenous group. There's very high rates of suicide. I'm talking about 5 times the national average in Canada. The indigenous people have very little trust in anybody except their own people. And there are no healthcare workers, very few healthcare workers that they can go to who are indigenous. So community resources, which are developed by indigenous people, are our partners now. So I try to work with somebody in the community who that patient or family trust. That's part of the bridge. The indigenous people have taught me to also be very humble. They will not talk to anybody who is outside their world. They have been shattered. And so trust, and how do you elicit trust, and how do you support the efforts of the indigenous people to look after their own? And how do we have what we call two-eyed seeing? That is, we see like a North American, but we also have to appreciate that the way that the indigenous people see North America is very different. So that we call two-eyed seeing. Okay? So again, I'm suggesting to you that if you really are interested in equity as a therapist, you are never going to stop learning. You are going to be learning all of your life from every single patient you meet, because you are going to have to figure out how you're going to regain trust and have enough humility to be able to learn that what is that person's point of view about distress and values and resilience. That would be my comment. And yes, I could share many profound experiences.
So many cases that might be coming to your mind. Definitely. Yes. Okay, thank you so much for your time. And I know it is 6:30 in the morning you have joined. So if there are no other questions, we can wind up. So good evening to one and all present with us, both online as well as offline. I would like to thank Professor Jaswant Guzder, the guest speaker, for accepting the invitation and for the several back and forth communications which made this event possible at 4 p.m. here, but which is a difficult time for Professor Guzder at 6:30 in the morning in Montreal. Listening to your perspectives shaped by long years of experience and expertise in psychiatry, that too with a very interdisciplinary outlook, I'm sure it has actually opened up eyes and ears to listen more to people, definitely, which is, I think, is very vital for any intervention. And I would like to thank all the participants and students who have joined across the country this evening and for your participation. I extend my sincere gratitude to the National Coordinating Institution, Unnant, Bharat, Abhiyan, IIT Delhi, for being with us always for guidance. Sri Prerna Sagar from National Coordinating Institute, IIT Delhi, has been ultra prompt in replying to my emails and also in planning and coordinating this event smoothly. Thank you very much. And I would also like to thank Sri Anuranj Kumar, who is the project coordinator of Unnant Bharat Abhiyan Regional Coordinating Institute, IIT Pala, for all the help rendered to make this event successful. And I would also like to thank Sri Shana from the Media Committee, IIT Palakkad, who has helped us in publicizing this event through social media handles. Thank you very much. And last but not the least, I would like to thank the IIT Palakkad CET team, or the Center for Education Technology team, support teams who have worked diligently behind the scenes in materializing this event, even though there were some technical glitches with regard to WebEx. But I would like to thank the team involving Sri Sonu and Sri Subodh and Sri Anurag for setting up this infrastructure over here and connecting us with Delhi as well as the rest of the country. And I would like to remember everyone who have helped us to make this event with utmost gratitude. And once again, I would like to thank the sign language interpreters, especially for in such short span of time they have taken their time off to consent and come over to do this event for us. And I would like to thank both of you for helping us immensely for making it more inclusive, this event. And also, I would like to thank Professor Guzder again for just not for the talk and the experience and the knowledge which has been shared, but also for being very warm and kind enough to actually discuss things, and for being an amalgam of both intellect as well as kindness, which I see very rarely in mental health professionals. So I think that might be the reason why you could do such great work in many countries in the world. Thank you so much. We'll wind up this discussion.
Prof.